So I'll be discussing on meniscal root test, focusing more on medial meniscal root repair. So we all know when we started our arthroscopy as beginners, at least in my first 4 to 5 years, I never repaired a meniscal root. So my focus was only on the ligament reconstruction. But later I understood the importance of the root tear. The incidence is also very much this thing. Almost 9.1% of all patients who undergone knee arthroscopy had a meniscal root tear. So by definition, it's a bony or soft tissue root avulsion within the 1 centimeter of the root attachment, either anteriorly or posteriorly on either side. So around these account for around 10 to 21% of all meniscal tears, which is a very significant numbers. So anti-horn tears compared to the posterior ones are not clinically significant. So the Choi et al. Has done a study on all the around 140 patients who has undergone the total knee replacement in less than 60 years of age, and they found 78% of all these patients had root tests. So the number is very significant. So root tests common in both acute and chronic settings. The degenerative tests are more common in the medial meniscus posterior root, whereas the acute tests, which are associated with the lateral meniscal posterior root tests, usually following a significant trauma. So the degenerative tests, which are more common, usually result from an acute this trauma, usually resulting from hyperflexion or squatting injuries. So the medial meniscus, unlike lateral meniscus, is less mobile and there is highest load transmission compared to the lateral, and hence the degenerative tests are more common on posterior root. So the meniscal root tests, they are important because they profoundly affect the dynamics of the knee biomechanics, because unrepaired root tear is almost equivalent to a subtotal meniscectomy. The forces which are there, so the compressive forces are transmitted into hoof stresses. This the mechanism is lost in case of a root tear. Unless we don't repair them, then invariably it leads to early degeneration of the knee. So earlier, the root anatomy was described with respect to the attachment of the ligaments, the ACL and PCL. Now we have a various the cadaveric studies, which in turn identify the exact location of the each root: medial meniscus posterior root, anterior, lateral meniscus posterior and anterior roots. Robert the Laprad in his the paper on current concepts on treatment of meniscal root tears has described the anatomical location of each root. So the patients at high risk to develop these root tears are patients with varus alignment, old age, high BMI patients, and female sex, and patients with sedentary lifestyle. Of course, spontaneous osteonecrosis of knee, either it is associated or sometimes it is the result of the existing root tear. So clinical features, as I said earlier, the classical clinical features and examination findings are not there for a meniscal root tear. That's why we initially miss these root tests. So a history of trauma will be there in a lateral meniscus root tear. Usually it is associated with other ligaments, commonly the ACL injury. Whereas in a degenerative root tear, they rarely give an history. Sometimes a small pop in the knee while getting from the chair or during deflection. You will have a joint line tenderness. Sometimes they can present with mechanical symptoms like catching, locking, and instability. McMurray's test may be positive, joint line tenderness, and sometimes you can even palpate the part of the meniscus anteromedially in varus position. So the diagnosis is a challenging one because there are no characteristic history pattern. There is no characteristic symptoms, and there is no the MRI specificity and sensitivity is also less compared to other diagnosing the existing other ligament is. If you take the sensitive specificity is only 73% and sensitivity is only 77%. So we can miss this root test if you don't focus on them both clinically and on an MRI scan, and you have to probe them specifically, especially the posterior part of the medial meniscus is very difficult to see and probe. You might do a pie crusting of the medial meniscus to open up the medial joint space. With respect to imaging, again, MRI is the investigation of choice. The sensitivity and specificity both are relatively poor. And there are some classical signs which are described for a root tear. So all the views, the sagittal view, the axial view, and the coronal view, you can identify the root tear. The sagittal view, you can see the anti-horn. There is absent posterior horn. We call this as ghost sign. Again, the signal changes are there on the posterior part of the root. There is a discontinuity and hypersensitivity signals you'll see. On the coronal section, close to the attachment, you'll see the hyperintensity signals. We call it as a truncation sign. So again, this is same this thing where apart from the changes, signal changes, you will also see the bony contusions in the uh, medial and lateral condyles of the femur and tibia. Again, you can very well make out extrusion of the meniscus if it is more than 3 mm on a coronal view, again classically diagnostic of a root tear. Again, this the well-known classification. So type 1 is close the partial root tear. Type 2, the radial tear within 1 centimeter of the this thing. Again, it is subdivided into 2A, 2B, 2C. Most of our repairs are in this type 2. This thing again, if it is associated to the bucket handle, it is type 3. Again, oblique tear type 4, and avulsion is type 5. So rationale of treatment of these tears to restore the joint contact pressures and joint kinematics and prevent the development of early osteoarthritis. So again, various treatment options. Of course, the non-operative and partial meniscectomy are not very much this thing because they invariably lead to early development of arthritis. Again, if the patient is having a tear and a surgical candidate, not a surgical candidate, do a non-operative treatment. If the patient is a surgical candidate, there is no contraindication, then acute meniscal root repair. If it is chronic, if there is a pre-existing arthritis, grade 3, grade 4 Klegren, then just a partial meniscectomy. If there is no arthritis, then root repair. So if you see here, either you manage non-operatively or you do partial meniscectomy, invariably is going to develop osteoarthritis around 95%, 99%. And if you do meniscal root repair, 50% reduction of the progression into the arthritis. So you should note that partial meniscectomy is worse than non-operative treatment. If you have to do a partial meniscectomy, you think about it, because so again, this is a small video, but again, I'll just I cannot fast forward it. So the basic steps of this thing is you first diagnose a root tear, probe it, then do a pie crusting of the medial meniscus, uh, curate the cartilage close to the root, then take a bite through the posterior and reattach. Can I show the complete video, Sandesh? So the gold standard treatment for meniscal root tear is transtibial pull-out technique. Either you can use a single tunnel or two tunnel technique. So take the sutures through the posterior root and fix it to the anterior part of the tibia, cortical fixation, either using a button or If you use two tunnel technique, need not use. Fast forward, fast forward. Okay. I think I cannot fast forward this video. I'll just skip the video. So transtibial pullout is the gold standard, either single or double tunnel. So the pike crusting is very important. Again, pike crusting, there is one article by Dr. Chechunjit Bancha from Thailand, where he has described the magical point on this TU line he calls the posterior tibial cortical line extending towards the adductor tubercle. 1.2 centimeter proximal to this joint line is uh, the magical point. So rehabilitation, non-weight bearing is very important. 6 weeks, you have to counsel the patient in advance that he has to not bear the weight for at least 6 weeks, and range of motion in first 2 weeks up to 90-degree, followed by further this thing. So after 6 weeks, he can progress to gradual weight bearing in another 2 to 3 weeks. Of course, there are some contraindications to root repair. All root tears will not go to repair if there is an advanced osteoarthritis grade 3 and 4. Again, chondromalacia grade 3 and 4, obesity, non-compliant patients, and poor surgical patients are contraindications. Again, to conclude, root tears, Robert Laprade calls them silent epidemic because of their the prevalence. Proper history and examination is very important, and MRI is the investigation of choice. Non-operative treatment and partial mastectomy does not restore biomechanics and anatomic root repair. Excellent results. Thank you.